So, Paras, can I start?
Yes, ma'am. I'm just going live. We are live now. I'm starting with all your permission this session. Yes, ma'am.
Okay.
Just give.
Yeah.
Yes, ma'am. With all your permission, I'm starting this session.
Yeah,
Good
sure,
evening,
sure.
everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, Dr. Ritu S. Santwani, ma'am. Ma'am has founder of CEO and 360-degree healthcare studio and Sham Well Women Clinic, an obstetrician and gynecologist, cosmetologist, and infertility specialist. Today, she is going to discuss on a topic medical management of PPH. What's new? By taking not much time, I would like to invite ma'am and hand over this session to you. Over to you. Kindly proceed from here.
Yeah. Thank you, Faraz. And thank you, IGCP Publications, for inviting me here. So, friends, today we are going to discuss a very, very important topic regarding what's the I will start sharing the screen. First, I want to speak something. So, today we are going to discuss very important topic that what's new in the medical management of PPH. We all know whether we are infertility specialist, whether we are a cosmetologist, or whether we are cosmetic gynecologist, or whether we are sexologist. Those whosoever is passing the obs gynae, of course, in the one or the another phase of our lifetime, definitely we all had done lot of deliveries, or maybe for the young budding gynecologist, this lecture will be more useful because earlier we are using only this pitocin and methergin. But now these days, what are the new advancements has come for the medical management of the PPH? PPH itself is a very vast term. So today I am going to cover the regarding the medical management. So just I will make it full screen. So friends, as far as introduced me, I am Dr. Ritu Santwani based at Pune. So knowledge sharing is my passion. So I always keep on posting lot of informative videos on my YouTube channel, on my Facebook, on my Instagram and LinkedIn too. So do connect with me in all these channels. By these discussion, we can increase our knowledge more and more. So yeah. So friends, as we all know, we all have gone through bad phases of the corona. My all presentations always start with Mata Durga Stuti. Ya Devi Sarvabhuteshu Chikitsa Rupena Sansita Namastasyai 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 Namo Namah. Before I start, I am really thankful to all of their participants, those who have joined. I know this is the just finishing time of the OPD, and we all are very tired throughout the day, and this is the time to take dinner and go to the bed. But I'm thankful to all of you, those who have joined. So friends, now for this medical management of PPH, what's new? My all slides on the background is showing the very famous. We all know the history that why this lady has expired, that why this Taj Mahal has been made. So now what's the incidence of PPH in India? So PPH is the leading cause of the maternal deaths in India. The prevalence in India is about 38%. It accounts for up to 56% of the maternal death in India. So 1/4 of all the maternal deaths worldwide, PPH accounts for 35 to 36% of the maternal deaths in India. So among the important causes like hemorrhage, unsafe abortion, obstructed labor, sepsis. Friends, by the routine definition of this PPH, when the blood loss is more than 500 ml following vaginal delivery and more than 1000 ml following the cesarean section, or any amount of the blood loss within the 24 hours after the birth, which is evidence in the pulse rate and falling BP. So as we all know, this PPH can be classified into the two categories, the primary PPH and the secondary PPH. So primary PPH means which is within the first 24 hours of the delivery, while the secondary PPH from 24 hours to 12 weeks after delivery. So we all know this is a very important question for the Viva examinations. I am focusing some points because I know some of my talks are attended by the budding gynecologists. So primary PPH means within the first 24 hours. And the secondary PPH from 24 hours to 12 weeks after delivery. So we all know the 4 T's of the PPH, the tone, trauma, tissue, and thrombin. Among these, friends, the tone is very important. Atonic uterus, 70%. Amongst this trauma is the laceration, hematomas, inversion, rupture. In the tissues, the retained tissue, invasive placenta, and coagulopathies. So friends, as we all know, the tone is a very important factor, the atonic uterus. Me being an infertility specialist, lot of patients I am give the treatment conceiving either twin pregnancy or triplet pregnancy, because in a year I am doing more twins and triplet pregnancy delivery compared to the singleton. So we all know, so this point has to be focused very properly. That tone is a very important cause for the PPH. So yeah. So now what are the risk factors for this PPH? So friends, as we all know, what are the abnormalities of uterine contraction, atonic uterus? So the risk factors are prolonged use of oxytocin, high parity, chorioamnionitis, general anesthesia, or the overdistended uterus when either the twins or multiple gestation, polyhydramnios, macrosomia. In the fibroid uterus, the multiple uterine fibroids, uterine inversion in the case of the contraction, short umbilical cord, and the fundal implantation of the placenta. The genital tract trauma, we all know, episiotomy, in sometimes the cervical, vaginal, or perineal lacerations, uterine rupture. In some cases, the risk factor is more in the cases of the precipitous delivery, retained placental tissue, in the cases of the previous uterine surgery, incomplete placenta at delivery, abnormalities of coagulation, preeclampsia, severe infection, amniotic fluid embolism, abnormal bruising, fetal death, placental abruption, fever, sepsis, hemorrhage, current thromboembolism treatment. So now we will take one by one what are the risk factors has been reported. The prolonged labor, grand multipara, augmented and precipitated labor, history of PPH, overdistended uterus, macrosomia, twins, polyhydramnios, operative delivery, chorioamnionitis. Blood loss can be estimated by weighing of compresses, visual estimates, collecting devices, and the shock index. The severity of the condition can be estimated by if more than 500 ml accompanied by risk factors, the abnormal condition. More than 1000 ml is the severe PPH, and more than 2000 ml is the massive hemorrhage. So by the WHO, the active management of the third stage of the labor is recommended for the prevention of the PPH. So in this, the active management of the third stage of the labor, what are the steps have to be monitored? First, the bimanual uterine massage, and simultaneously the uterotonic agent administration. So friends, here we can see the profile. Is my voice is clear for us? So the prophylactic administration of
Yes, ma'am, it's
uterotonic.
clear, ma'am.
Okay, thank you, dear. So prophylactic administration of this uterotonic agents identified as a very important factor in the management of the active management of the third stage of the labor, as it reduces the incidence of PPH nearly by 50%. So friends, what the studies have shown, the cesarean deliveries have become an epidemic in the record 3% jump in the last decade. Cesarean birth rate in India has crossed WHO threshold of 15%, says the study. So The incidence of PPH are high in the cesarean deliveries, 6.75%, than in the vaginal deliveries, 2 to 4%. So we can see, friends, in the vaginal deliveries 2 to 4, while in the cesarean deliveries 6.75% has been reported. While this PPH is more likely to be happen after the cesarean as compared to the vaginal deliveries, approximately 36% of the cesarean deliveries are complicated by PPH. And therefore, it is a very common practice to give this uterotonic following the delivery of the neonate during the cesarean section. We all know we all are using either oxytocin or methergin earlier, or sometimes the symptomatrin, the combination of oxytocin and methergin. But these days, what the new drug is available, which we are using from last 2-3 years and giving a very, very good results. So in 2019, the international consensus statement on the use of the uterotonic agents during the cesarean section, uterotonic agents like oxytocin and carbetocin recommended for the routine administration immediately after the delivery of the fetus during cesarean section to prevent PPH. Administration of uterotonic drugs or agents is very essential during the cesarean section and in the third stage of the labor. So as I just discussed, so what we are using, the oxytocin, carbetocin, then the ergot alkaloids in the ergometrin and methyl ergometrin, and amongst the prostaglandin, PGE2, misoprostol, and carboprost. So we all know this oxytocin and carbetocin has been used as a first-line agents, and these two as a second-line agents. So oxytocin is considered as a gold standard treatment for the prevention of PPH. But now what are the things has been reported? So friends, here we can see the oxytocin is a short acting, half-life is 4 to 10 minutes, and duration of action is 15 to 20 minutes. And it must be administered as a continuous IV infusion to attain a sustained uterotonic activity throughout the surgical procedure in the postpartum period. While how it acts, here we can see, friends, that it causes the receptor desensitization. Oxytocin is used for inducing or augmenting the labor, may desensitize the oxytocin receptors and thereby impairing the oxytocin post-delivery effects on the uterine contractility. So various international bodies and trials have used and recommended the different doses of the oxytocin, but there is no consistency in the dosage regimen, which results into the errors in its administration. The Institute for Safe Medication Practices added the IV oxytocin to their list of high alert medications, meaning the minor errors can cause the significant harm to patient. So in addition to its use as a labor-inducing drug, oxytocin has over the past decade has been used in the dairy industry, dairy farming sector, where its properties as a lactation enhancer has been used to increase the milk production amongst the milk animals. So this drug has also been used to increase the size and speed up of the ripening and conversion of the starch to sugars process in fruits and vegetables. So there is a oxytocin ban notification has come due to the misuse of this drug in April 27, 2018. It prohibited the private sector companies for manufacturing and distributing of the oxytocin for the domestic use. And only at present, only the one public sector unit, namely in the state of the Karnataka Antibiotics and Pharmaceuticals, are granted a monopoly to manufacture and sell the drug to meet the requirements of the entire country. So what's the need of the hour? Need of the hour, the drug should be longer acting, single dose of administration, no variation in the dosage regimens, devoid of repeated administration, ease of one-time administration, superior efficacy or similar efficacy as that of oxytocin, devoid of receptor desensitization, and it has a superior side effect profile over the oxytocin. So it is what is carbetocin? So friends, so this carbetocin is a synthetic analog of human oxytocin with some structural modifications. This structural modification increases the half-life of the carbetocin therapy by prolonging its pharmacological effects. So it acts through the oxytocin receptors, which causes the uterus to contract. So it is having oxytocic activity, uterotonic activity, and anti-hemorrhagic activity also. So here I can show this video.
A postpartum hemorrhage, or PPH, is an obstetrical emergency affecting an estimated 10% of all live births. It is the most preventable cause of maternal death. The uterine arteries pump 500 to 700 milliliters per minute into the site at which the placenta is attached to the uterus. After birth, this blood could potentially flow into the uterine cavity and be lost from circulation. In most cases of vaginal delivery, however, the myometrium contracts firmly, compressing the blood vessels and thereby reducing blood flow. A cesarean delivery can increase the risk of a PPH developing due to the insufficient contraction of the uterine musculature. Carbetocin specifically targets uterine atony. Carbetocin is administered as a single intravenous injection. After injection, carbetocin is carried rapidly to its site of action, the smooth muscle cells in the uterus. Here it binds to oxytocin receptors. In this way, a signaling cascade is started. As a result, the smooth muscle cells of the myometrium start contracting regularly. This causes the leaking blood vessels in the uterus to be compressed and to constrict. The overall effect? The bleeding stops and uterine involution is furthered.
So this carbetocin, the half-life is 40 minutes, is approximately 10 folds higher than oxytocin, which is 4 minutes. The duration of action of carbetocin is also longer than IV and IM oxytocin. So friends, the studies have shown that the single IV bolus injection of carbetocin was at least effective as 16 hours of continuous oxytocin infusion. The carbetocin, no need for the repeated administration. And no dosage variation in the single dose of the carbetocin is found to be effective in controlling the PPH, unlike oxytocin. Farhas, I am getting some request on my WhatsApp. Some doctors from the Andhra Pradesh, the Dr. Niharika. So she is not able to join. She is writing that I am again and again trying but not able to join. Is it some problem?
No, ma'am. It is live on YouTube also. She can watch on YouTube too, MedTalks platform.
Okay.
Yeah.
I'm just, yeah.
MedTalks. Just
Yeah,
the.
MedTalks. Yes.
Yeah.
I have. Yeah.
Okay.
Yeah. Thank you. So, thus, the carbetocin is superior over oxytocin with respect to its pharmacokinetic parameters and single dose administration. So, what the studies have shown by WHO? WHO has shown the safest and most effective medicines needed in a health system. So friends, here we can see that for the PPH prevention and PPH treatment, effective treatment options for the FIGO recommendations, what they suggest. So friends, here we can see the, for this, by the FIGO recommendation guidelines, the oxytocin is the PPH prevention prophylaxis. In this, friends, we can see the first line prophylaxis is 10 international units per ml IM or 5 international units slow IV push within the first minute after the delivery. While the ergometrin is 0.2 mg IM within the first minute after delivery, or the misoprostol 600 microgram orally within the first minute after the delivery. While coming to this PPH treatment, oxytocin, this all is a prevention prophylaxis, and now for this is oxytocin 10 international units IM or 5 international units slow IV push, or 20 to 40 international units per IV fluid infusion. Misoprostol is 800 micrograms sublingually. Ergometrin or methyl ergometrin 0.2 mg/IM, which can be repeated every 2 to 4 hours, or the symptometrin, the combination of two. And while the carbetocin is used as a PPH treatment, so 100 microgram IM or IV slowly over the 1 minute, or the carboprost, as we all know, 250 microgram IM over the 15 minutes maximum to up to the 8 injections, means up to the 2 gram we can give. 2 milligram we can give. So now what are the guidelines have come for this from the FOXY? So the friends, the guidelines have shown that this oxytocin 10 international unit intramuscular or 5 units IV diluted over 5 ml over 1 to 2 minutes, or 20 units and 500 ml of normal saline or ringer lactate. And the onset of action is 2 to 3 minutes, which lasts up to 15 to 20 minutes. Misoprostol 800 microgram orally, sublingual and parectally. Onset of action is 3 to 5 minutes. Peak is in 20 to 30 minutes. Last up to 75 minutes. Or the ergometrin or the carboprost. By in AICOG 2019, this carbetocin has been proved for the atonic PPH. The total duration of single injection of IV carbetocin on uterine activity is about 1 hour. Hence, only the single dose is needed, and it has an effect on the pregnant and immediate postpartum uterus, and no effect on the non-gravid. And bioavailability of this drug is around 75 to 80%. So again, here we can see, I've just shown, so I will skip this slide. So this has been recommended by the WHO also as an effective uterotonic. While the carboprost which we are using, it is actually not recommended by the WHO, because with that carboprost we all know a lot of side effects like nausea, more nausea, vomiting, and diarrhea has been reported. I still remember that time once we are using this carboprost, we usually give along with that the lopramide and this ondansetron injections also. And so this is again, I'm showing the guidelines which has been by the FIGO recommendations for the management of the PPH in March 2022 only, which has all support the use of the carbetocin. So it has been studied throughout the world. So a lot of clinical trials has been posted regarding the safety of this drug. So yeah, this actually all I have covered. So I'm taking in the nutshell. I will show the last slide, which shows the comparison of in both these. So by this all has been reported the postpartum blood loss is less with this carbetocin, and need of additional uterotonic drugs is also less. So once the blood loss is less, so it will IV carbetocin is more effective than IV oxytocin for the prevention of the atonic PPH amongst the singleton pregnancies with at least one risk factor for the PPH. So there are a lot of articles has been presented for the favor of this. This I will skip because we all have discussed all this. So yeah. So there are a lot of studies which all shows that the additional uterotonic were needed less frequently by the patients treated with carbetocin, and carbetocin appears to be an attractive alternative to compared to oxytocin and the misoprostol for the prevention of the atonic PPH following cesarean delivery. So lot of studies, these are in detail studies by the different authors, which all shows that this carbetocin appears to be more effective than oxytocin for several hours on the uterine contraction and through preventing the postpartum hemorrhage in multiple pregnancy patients and undergoing elective cesarean section. So I will show. These are the all different studies which will show the favor of this. that how this drug is more useful. Actually, this was my oration lecture in one of the conference where I have to explain all these things for 1.5 hours. So today, because I already crossed half an hour time, because our program is scheduled for half an hour. So for the women who are undergoing cesarean section, this study has with the Cochrane, the carbetocin has resulted in a statistically significant reduction in the need of the therapeutic uterotonics compared to oxytocin. So it is having the comparatively less side effects. So these are the different studies which has been presented by the different authors. All are in the support of this. So I will show the what are the recent studies. This one study has been presented in the February 2021, which has shown the significantly good results, especially in the cesarean sections in the patients of the twin pregnancy. So yeah. So the studies have also shown the carbetocin and oxytocin for the prevention of the PPH in the cesarean deliveries for placenta previa and accreta. So all studies have favored uh, the use of the carbetocin, especially in the cases of the placenta previa also. And in the some patients with the history of the cesarean section with severe preeclampsia also. This has also been published in 2021. So studies have shown that no special hazard for the human beings has been reported, and carcinogenicity studies have not been performed with carbetocin due to single dose nature of the indication. So no such side effects has been reported. So this drug has been used safely for the prevention of the PPH. Again, friends, I will show this one comparative chart because carboprost is considered to be the second line, while the carbetocin has been considered as the first line in the PPH, and it has been recommended by the WHO, and no side effects like vomiting and diarrhea, which has been reported by the carboprost. And we all know the carboprost we can't give in the patients of the asthma. So that two advantages are here, that no vomiting, no diarrhea, and it can be given safely in the patients of the asthma, and recommended by the WHO guidelines also. So friends, here we can see this drug is helpful in the cases of the prevention of PPH, estimated blood loss after delivery, need of the additional uterotonic, decrease in hemoglobin levels, need of blood transfusion, perception of pain, and side effect profile. So lot of studies has been done by the champion trial for the usage in the Indian scenario. So this trial has been carried out by the WHO for carbetocin versus oxytocin across the 23 centers in 10 countries, including the India. So these are the centers, and this drug has been proved to be non-inferior to the oxytocin with the ease of the single dose administration. So lot of studies have come now in the superiority of this drug. A single dose of 100 microgram 1 ml should be administered IV as a bolus injection or slowly over 1 minute after the delivery of the infant. So we have to remember these points. Earlier, some companies have made the preparation which are not heat stable, but now these days the different companies are having the different preparations. We are having the tab injections, which are now these days we are getting the preloaded injections, and that too are the heat stable, which we can keep in the room temperature also. So day by day, lot of advancement and lot of advantages we are getting by this using of this drug. And last, I want to show some questions which are related to this. I get from the once I presented, so I made the slide this time. So what are the contraindications? So friends, this drug cannot be given during pregnancy and labor before the delivery of the infant. It must not be used for the induction of labor. In the cases of the hypersensitivity of carbetocin or oxytocin, in the cases of the hepatic or renal disease, serious cardiovascular disorders, and in the patients of the epilepsy. So breastfeeding does not need to be restricted after the use of the carbetocin. So studies have shown, friends, that, yeah, last line I will show. that all the pregnancies are at the risk of the PPH, even if no predisposing factors are present. So while dealing, we have to be very conscious while once we are dealing with any of the patients. So we all know the delay in the recognizing and seeking the help, delay in the transport and reaching the medical facility, delay in receiving the adequate treatment, and fourth D is very dangerous, is the death on the table. So that is also very, very important. So intelligent participation, skilled supervision, prompt detection, and effective institution of therapy can prevent the disastrous consequences of PPH. So once we give this, the lady who really has a bad history of the PPH, she is always worried about the same catastrophe in this time also. But usually once post-delivery, we give this injection, very good results we are getting. So the some common questions with this, yes, the carbetocin affect the infant and lactating mother? No, no problem with that. It can carbetocin can be used by after using oxytocin for induction of labor. So yes, after oxytocin, you can use this. No, it is not contraindicated in the patients of the asthma. Can it be given intramuscular? Yes, it can be given, but preferably we are giving the IV. Need of re-administration. So no need of the re-administration. No such scientific studies has been there. And what about the interaction with the tranexamic acid? No such studies are available. Yes, it gives better results compared to the misoprostol, and no studies that it causing the neonatal jaundice. And like this, lot of safety profile has been reported. And in why it should not be given in the patients of the epilepsy, because the conditions have shown that in the animals it is shown to be having an antidiuretic effect leading to hyponatremia. Yes, it can be used cautiously in the patients of the migraine, in which the rapid extracellular water may produce hazard of an already burdened system. It can be administered in the patients. No, patients who are allergic to oxytocin, this drug cannot be given. So, thank you, dear friends, for your interest and time. Sorry, I already exceeded for 2-3 minutes. If there are any questions related to this, I am happy to discuss with you all.
Yeah, thank you so much, ma'am, for taking out your precious time and sharing your knowledge with us and making this session informative ones. I definitely think this session knowledge is going to help all the participants who have joined this session. We have received some question from the participant end. Ma'am, if you allow, can I take this
Yes,
question with all your permission?
please. Yes, please.
Yeah, ma'am. The
Yeah.
first question I can see is, what are the contraindications to surgery for PPH?
Now, today my topic is related to the medical management of the PPH. So please try to ask me the questions related to that. I want to be focused answer. Currently, I'm having one patient. I have to go and operate. So it's related to this topic. I'm definitely happy to answer. Rest all this will take a lot of time.
Okay, ma'am. Thank you so much, ma'am. Moving
Huh.
forward, I can see another question. What is included in the fluid resuscitation monitoring during the treatment of PPH?
Okay. Fluid resuscitation monitoring.
Yes, ma'am.
Again come question. Question, please again repeat.
Yes, ma'am. The question is, what is included in fluid resuscitation monitoring during the treatment of PPH?
Okay. See, PPH management itself is a full bundle of treatment. We have to be keep all the things ready. Yes, depending on the patient's other parameters, we decide the fluid which we are giving, and depending on the what's the patient's pre-hemoglobin and how much is the blood loss. Yes, with this drug there is no problem, but what's the input and output? So we are not going to decide by ourselves. If we are doing the some cesarean section, so at present, we are taking the help of the anesthetist also. And suppose if we are doing the normal delivery also, so I always try to take one opinion from the intensivists also, which are the doctors we are having of the internal medicine, the intensivists. They also come, and accordingly to the patient's parameters, we decide. There is no such a tailor-made protocol, but definitely what the fluids we have to give, the input and output we have to decide depending on the patient conditions, patient parameter at that time, and what is the parameters.
Okay, thank you so much, ma'am, for explaining it really well. I know, ma'am, you don't have the time, but also you have taken out the time for this session, ma'am. We are very thankful. We can see couple of questions are there. We will be taking last two questions for today's session. The question is, what is included in the post-operative care following surgery of PPH?
Ask questions related to medical management. No surgery. No surgery.
Oh,
Today the topic is the
okay.
medical. Be specific.
Okay, ma'am. The last question I can see is, what is the role of ovarian artery ligation in the treatment of PPH?
Again, this is a surgical medical management. Today I am speaking only the medical management.
Yes, ma'am. But I
Only.
can see, ma'am, the audience are, I
Then
think
I
they
will
are
take
feeling.
another lecture for the internal iliac artery ligation I can take, in which we can discuss about the surgical management of the PPH.
Okay,
In that
ma'am.
we
But
can discuss the surgical management of the PPH.
okay,
Yeah,
surely,
yeah.
ma'am. As of now, I can see, ma'am, there is no more question related to this topic, ma'am. As there is no more question, ma'am, shall we conclude this session with all your permission?
Yes, yes, please. Yes, please,
Okay,
dear.
thank you so much, ma'am, once
So,
again.
friends,
And
anyhow, you are having any question? Yeah, if the frameworks once I will become free, I will definitely love to answer all the questions. For the surgical management, we are going to take the another lecture for the same, for the PPH. Yeah,
okay,
yeah,
ma'am.
Paras, you
Thank
can
you so
conclude.
much. Yeah, ma'am. Thank you so much, ma'am, once again. And hope to see you again with different topic, another topic, ma'am. Till then, take care of yourself and good night. And it was a wonderful session, ma'am. Thank you so much once again for your precious